come to the third and last speaker of this session, Professor Raman Puri, MBBS, MD, DM, cardiology, a senior interventional cardiologist, Apollo Hospital, New Delhi, India, founder chairman, Lipid Association of India. It gives me great pleasure to invite Professor Puri to address the audience now.
Yeah, thank you very much. And good afternoon, everyone. And special thank to Dr. Rashid Mubarak for calling me for this conference for the second time and giving me an opportunity to talk on novel and forgotten ASABD risk factor. To be very frank, this is my first presentation on this topic. I have never spoken on this topic, but I'll try to give you the maximum information. Where is this? Okay. This one? Yeah. What is common in these three pictures, and this is very important for us to understand because we have 5 major ASCVD risk factors, or traditional risk factors. Based upon these risk factors, various risk calculators have been there in the market. They are there in the market for the last many years. And we have been assessing the ASCVD risk based upon this as with the first talk score system of European system and Poole-Kohard equation of USA was also spoken about. But if we look into this picture, there are some points which really put some query into the the success of these risk factors, that they are able to really do justice to the patient. Now, looking into the Churchill, number 1, he was a heavy smoker, obese, sedentary. Hopefully, he was under a stressful job. He enjoyed life up to 91 years and died of myocardial infarction at 91. Jim Fixx, a marathon runner, non-smoker, died of MI at age 52. Tim Russert, a news anchor, very important person in USA, he got himself checked. His cardiac evaluation was done. Two months later, he died in the newsroom. His stress test was negative, and his lipid profile was normal. Now the question comes that, despite these, all important people were under medical supervisions, and they were all treated with the scientific evidence treatment. Why this gap, despite we have very good risk prediction modules? This means these risk prediction modules fail sometime. Another important information is that most myocardial infarction occurs in young patients without risk factors. This is a small study of 222 patients who had first myocardial infarction at a young age, less than 50 years. And 70% of these patients, based upon Framingham risk equation, was in low risk group, and 18% in moderate risk group. And 75% of these patients were not fit for pharmacotherapy. Now question comes, were these patients really in the low risk group? Then a pooled analysis of 4 studies shows that majority of myocardial infarction or acute coronary syndrome occurs with the lesions less than 50% obstruction. Now the concept of obstruction is no more there. Now we look into the plaque morphology, which is very important, because irrespective of the degree of obstruction, if the plaque is vulnerable, the patient is going to have acute coronary syndrome. And there are 2 important features. There are a number of important features, but 2 important features is the fibrous cap thickness. If it is less than 65 micron, and if the plaque burden is more than 70%, these 2 important morphological features makes the plaque very vulnerable. So irrespective of the lesion, obstruction severity, if it is a vulnerable, the patient will get acute coronary syndrome if the plaque is in an in-coronary system. And in another one study involving 136,000 patients in USA, it's a national study, the lipid profile was normal in those patients who were admitted with coronary artery disease. So all these questions, put some questions in our mind that what are we doing justice by just sticking to the traditional risk factors? Are there some shortcoming in our assessing the risk of the patient? Are the low-risk patients really low-risk patients? Are the low-risk patients not the extreme risk group where we are really missing this diagnosis? Or do we require more risk factors to re-stratify our patients into the risk categories. So we are really looking for those risk factors which can improve the net reclassification index, what NRI is. And if you look into the list of these factors, it's a large number, and 2 or 3 of important risk factors have been just now discussed, like NAFLD and metabolic syndrome and central obesity, which is absolutely maybe in our next 23 risk algorithm which we are coming out, we are possibly going to incorporate these risk markers. It's not possible to, go for investigating all these risk markers, but there are some important risk markers which are like high sensitive CRP, coronary artery calcium score, genome-wide score. These are extremely important because we have a strong scientific evidence in favor of it that they are associated with cardiovascular event. But there are other factors which you have to really look into it, like air pollution, social deprivation or depression. They also contribute to, coronary artery disease or increases cardiovascular event. But it is very difficult to, quantify them. So therefore, you cannot go for a randomized controlled trial to prove that this is the benefit you get from pollution index of this versus pollution index of this, because it becomes difficult. So while assessing the ASCVD risk of a patient, you have to look into all these particular risk factors and try to, stratify your patient into the real risk group. That is the only way we can definitely help in reducing the cardiovascular event. Now, coming to some of the studies which shows that non-traditional risk factors or new risk factors are important. This is a study of 1.1 million, subjects with acute myocardial infarction in younger population. Here we can see the odd ratio of traditional and non-traditional factors are almost similar. Rather, non-traditional factor like HIV has more odd ratio for acute myocardial infarction as compared to smoking. And obstructive sleep apnea, which we normally attribute that it will cause either diastolic heart failure or hypertension or atrial arrhythmia, is also one of the contributory factors for cardiovascular events. And very rarely, and I think most of us, and before I prepared my talk, even I was not aware of these non-traditional risk factors like frailty index, activity of daily limits, glaucoma, arthritis, sinusitis, though it was shown to have a significant impact on cardiovascular events in one of small studies. We do require further studies to confirm it, but they have a possible relations to the cardiovascular event or the incidence of incident coronary artery disease. Therefore, since coronary artery disease is a multifactorial disease, you cannot, say that one factor is going to cause myocardial infarctions, other will not do it. You have to keep your eyes open and you to use your clinical sense to find out what else can be the risk factor in this particular patient. American ACC in 2018 incorporated many of these risk factors. They were called as a risk enhancer, and even Lipid Association of India in our latest algorithm incorporated some of these risk factors, and we incorporated only those risk factors which had a scientific evidence of their association with cardiovascular event, like coronary artery calcium score, the carotid plaque of more than 50%, then high sensitive CRP, and impaired fasting glucose and increased waist circumference, which is very important part of a metabolic syndrome. We incorporated in our latest recommendations. Now, coming to some of these markers, risk factors, like carotid intima media thickness was used for a very long time and still being used to assess subclinical atherosclerosis, especially in small kids with familial hypercholesterolemia. But it has a variable, results. Some studies says it is useful, some studies says it is not useful, and its result depends upon, expertise who is performing this procedure, at which area or which segment of the carotid system it is being evaluated. Therefore, it is ACC now says that probably this is not a better investigation for assessing subclinical atherosclerosis, rather more emphasis on carotid plaque. That is very important because when you assess carotid plaque, you assess its size, its volume, its height, its morphological features. All these are extremely important than just measuring the thickness. Therefore, more emphasis now on carotid plaque, and which of course can be graded into mild, moderate, and severe depending upon the thickness. And the MESA study has shown that, in which MRI was done, that remodeling index, lipid core, and calcium in the internal carotid artery has strong relations to the cardiovascular events. This is something new, that femoral artery plaque has strong relations to coronary artery disease. This is a study from Spain, basically Fuster study, in which they have done, carotid ultrasound and femoral ultrasound and coronary artery calcium score in Aragon workers. Basically, they are from GE Motors, and all the workers, male workers, were screened for these non-invasive procedures, and they found that the incidence of subclinical atherosclerosis was 72%, and majority of these patients, about 54% of these patient population, not patient population, had femoral plaque, more than carotid plaque, more than coronary artery calcification. And the odd ratio of femoral artery plaque to coronary artery calcification was much stronger than the carotid plaque. So therefore, it's a very simple procedure, doing a femoral ultrasound, which of course is very less used, probably will be one of the most important indication in near future, has strong relations to cardiovascular coronary artery calcification and subsequent cardiovascular events. Not many studies are available. One of the study which we found was a Turkish study of 215, asymptomatic middle-aged population, and it was found that there was increased incidence of MACE by 4.2% in those patients in which femoral plaque was detected by ultrasound. And one unique feature in this study was that the femoral artery plaque surface, if it is irregular and ulcerated, has an hazard ratio of 23, as just slightly less than the hazard ratio associated with coronary artery calcium score. So I think that if you evaluate your patients non-invasively with carotid ultrasound or carotid and femoral ultrasound, these two investigations will be of great importance in just trying to rule out that whether the patient has evidence of subclinical atherosclerosis or not. Now, coming to the most important risk marker, I think that probably this will not be a risk marker. This will become a traditional risk factor now in years to come. Maybe you will find we will give a special place to coronary calcification in our upcoming ASCVD risk algorithm, which will be published in 2023. What you see is 20% of the plaque. 80% you will diagnose the fibrotic component and lipid-rich component by the intravascular ultrasound only. With MRI, you can only see 20% portion. If the coronary arterification goes up, the plaque volume goes up. And therefore, it has a strong relation to cardiovascular events. We all know that South Asians have higher incidence of coronary artery disease. Here, based upon MESA study and Masala study, it has been seen that the calcium score is higher in South Asians. Males especially start increasing from young age, somewhere around 50 years, and it continues to increase at older age. Whereas in women, it starts rising in the old age. It was not in the early age. And this may be one of the reasons that why do we have higher incidence of coronary artery disease. If we add a risk marker in addition to Framingham risk score, which is the basic risk score, what C statistics or what is the area under the cover you are going to achieve with various risk markers, this slide shows. What exactly it means, that if I use coronary artery calcium score with Framingham risk score, the area under the cover, which you can see, the red line at the top, is much more than the other markers. This means there is increased sensitivity and specificity, so you diagnose the disease much better with adding calcium artery score along with Framingham risk score as compared to the other risk markers. So therefore, among the other risk marker for calcium artery score has a better place. It gives you more information. Remember that calcium artery score, when we are talking about, it is not recommended for patients with very high risk group, extreme risk group, and high risk group. Because in this group, we have no doubts about our treatment strategies. There are specific goals of LDL cholesterol. There are specific goals of non-HDL cholesterol. The controversy only comes in low risk group and moderate risk group, that whether we have to start the statin treatment in these patients or not. So when this calcium artery score is used along with intermediate risk group patients, you can see that 14% of these intermediate group of patients or moderate risk group patients are reclassified as a high risk group. Means without calcium artery score, you are underdiagnosing the severity of the patient disease. And on the other hand, 63% of these moderate risk group patients or intermediate risk group patients were reclassified as a low risk group patients, means their severity was much less. So that shows the importance of coronary artery calcification. Now, another important advantage of doing coronary artery calcification is that irrespective of the risk factors, whether there is a risk factor 0 or risk factor 3, if there is no coronary artery calcification, the events are very less, even in no risk factor or 3 risk factor. And if the coronary artery calcification is more, then irrespective of the risk factor, the events are higher. Means if the your patient has no risk factor and coronary artery calcification is high, he is going to have more events. So you have to treat them aggressively to reduce these events. And based upon Agatston's scoring, they can be classified as mild, moderate, and severe. It is important for us to understand because the probability of having at least one artery more than 70% blocked is higher with more severe coronary artery calcification as compared to those in which there is no coronary artery calcification. It has been seen that higher the value of coronary artery calcification, higher are the cardiovascular event, higher are the cardiovascular mortality. And 10-year MACE is around 37% if the coronary artery calcification Agatston score is more than 1,000, as compared to just 1.1% when the calcium score is 0. And even not only the events, even the mortality you can see is much higher when the coronary artery calcification score goes beyond 1,000. Another important advantage of coronary artery calcification is de-risk stratification. Means that the patient who was initially stratified as a particular high risk, the risk comes down if the coronary artery calcification is 0. Now, there are some patients in which you recommend statins. There are some patients in which you consider statin. If there are coronary artery calcium score is 0, it reduces the number of these patients in which statin is recommended or statins are considered. This is one interesting study in diabetes patients with the duration more than 10 years or less than 10 years. Those patients of diabetes in which calcium score is 0, whether it is diabetes less than 10 years or more than 10 years, it is much less as compared to those patients of diabetes in which coronary calcium score is more than 400 Agatston units. So that is important. So if, for example, your diabetic patient comes, first thing, according to our algorithm, once patient is diabetic, there is no need for any coronary artery calcification investigations required, because once patient is diagnosed as diabetes, he is a high-risk group, and the target of LDL cholesterol is less than 70 milligram, irrespective. And if diabetes is with the target organ damage, then he is a very high-risk group, and target is less than 50 milligram. So in diabetes patient, according to Lipid Association of India, there is no need for coronary artery calcification. However, this is a study which I am quoting, that this has been shown that if there is no coronary artery calcification in diabetic patients, the events will be much less. And one study shows that it gives you warranty for 15 years that you will have no cardiovascular event, but that is too much of a statement, because coronary artery disease is a multifactorial disease. One particular risk factor cannot change the natural history. However, if the patient you think is of a high risk, the risk has increased, it is important you can repeat this coronary artery calcification in every 5 years. Now, what is the threshold of starting statin in patients with coronary artery calcification? It is seen that once the coronary artery calcification is above 100, then there is a benefit of reducing event. Below 100, there is no benefit. Now, one picture speaks 1,000 words, is what is this slide of this coronary artery calcification shows. Once a patient comes to know that his coronary calcification is high, it has been seen that his blood pressure is lower, his LDL is reduced, his waist circumference, he is able to bring it down, he is able to bring down his weight, and as a result of this, his lifestyle, all the parameter is much better as compared to those patients in which the calcium score is 0. Overall, I'm going because time is not there. If we put coronary artery calcification score in the risk calculator, we'll be able to calculate the risk much better, more correctly as compared to those in which the calcium score is not included. And what age should we do it in a young age? It is said that in South Asian, coronary artery calcification doesn't appear before 30 years. And normal age in which it is recommended is 40 years and plus in most of the guidelines. We don't have our own guidelines so far. But what we have been recommended is the algorithm which we'll be publishing shortly. It's a complex because of the time I will not be able to go into the finer details of it, but this gives you how you should proceed, how should you go for coronary artery calcification, how you should interpret coronary artery calcification in patients with South Asians. Now, the one of the topmost indication of coronary artery calcification is intermediate risk group or moderate risk group, where you have a doubt whether you have to give patients statin or not. Of course, there are other indications also, but this is the most important indications. Now, coming to lipoprotein A, just few words. We know that it is prothrombotic, proatherogenic, pro-inflammatory. 25% prevalence associated with coronary artery disease. There is one trial, Horizon trial, undergoing trial, which will show that if we reduce lipoprotein small a, does it reduces events or not. High sensitive CRP is again another risk marker, which of course we have shown that by giving Canacomab, which brings down high sensitive CRP by 34%, interleukin by 6, there is 15% reduction in event, but still it is not approved by FDA. Then we have shown, I have said before that impaired fasting glucose and metabolic syndrome and central obesity, they are all associated with increase in cardiovascular events. So that should also be looked very seriously in all patients in which you are stratifying the patients for ASCVD risk. And of course, genome-wide association will be able to, based upon these. There are in patients with premature coronary artery disease, there are about 17% of these patients have abnormal SNP which associated with coronary artery disease. So in those patients who are in high risk group, if we are able to find out these SNP, we will be able to have more aggressive preventive strategy in this group of patients. So the take-home message is that you stratify ASCVD risk category based on traditional risk factors. Look for other non-traditional risk factors, especially carotid ultrasound, femoral artery ultrasound, coronary artery calcification score, including other moderate risk non-conventional risk factor as per LAI risk algorithm in low risk group and moderate risk group. Look for other risk marker, including inflammatory bowel disease, HIV, obstructive sleep apnea, SLE, as they add to the cardiovascular event. Air pollution, frailty index, and social factors should also be considered in ASCVD assessment to improve NRI. Reclassify ASCVD risk category and fix LDL cholesterol target. Achieve LDL cholesterol, non-HDL cholesterol target, and if possible, ApoB, especially in patients with very high risk group and extreme risk group. Thank you very much for your kind attention.
We would like to open the house now for some questions. We have about 5 minutes left for questions.
If I may just start off, This was a very interesting session, and I hope the audience realizes the importance of this, because the WHO says that every year 18 million die of cardiovascular disease. 18 million die of cardiovascular disease. And for the entire COVID, only 6 million have died. Right? So 3 times that every year. And we are here trying to prevent that. And there are so many ways: primary prevention, how to identify the risk people. So WHO basically defines the traditional risk factors, but there are 3 levels of causation. The next level is urbanization, lifestyle, those things. But finally at the bottom, it's national policies, poverty, genetics, that sort of thing. So today we have heard a lot of 3 different areas about this coronary artery disease prevention. The cardiovascular disease basically involves renal CKD and stroke and heart attack. So 75% is stroke and heart attack. So that's what we are more concerned about here. So I think all of us actually encounter Mr. Fit and Mrs. Risk. So I don't know whether personally I'm still not sure how to handle those 2 after the lectures. So Mr. Fit is a 35-year-old guy, and he basically has no risk factors, and he wants to know his cardiovascular risk, and he comes to you. So would you not do anything? Will he be happy with that? And then on the other hand, Mrs. Risky is 50 years old with all the risk factors and asymptomatic. So just 1 second, I think now the presence or absence of symptoms is also very important in these people. So obviously in the cases you presented, we'll assume that they don't have any symptoms. So going by the evidence, the ESC chronic coronary syndromes, so they are obviously not ACS, so we want to see whether they are candidates for the CCS. So CCS has 6 categories, and one is basically asymptomatic people detected at screening. So based on that, what sort of screening would be warrant for these people to see whether they have underlying coronary artery disease?
Now, if you get the first question that Mr. Fit, right? And now, can you guarantee him that he will not get a heart attack in 10 years' time? No one can guarantee. And the only thing is you can assess his 10-year lifetime risk. Lifetime risk is always will give you a figure. That it will give you a figure. There is a 15% chance he will die. He will be a healthy person. But we also can predict that anybody can die of myocardial infarction. But you must realize, even though he is healthy, now you have a national plan on prevention of coronary artery disease. He has to follow the healthy lifestyles. He has to continue to follow his healthy lifestyles. He has to check his cholesterol, keep the cholesterol down, weight down, activities, everything. If we continue that, then he will remain in that lower risk category. But no one can guarantee that he will not get a heart attack. The other patient, the Mrs. Fit, she has a lot of risk factors. Now, that is the patient you have to screen, because individual screening, because that patient qualifies for an individual screening. So you have to screen this patient and see whether we have to do a calcium score or an exercise test or even a CTCA if it's warranted, to find out whether she has to be put on high dose statins and whether she should be vigorously treated. That is also after assessing her risk. In that patient only, these risk scores help. The risk scores help. You assess the risk score. If it is false, goes beyond 5 to or 10% or so, then he should be vigorously investigated. If it is between 5 and 10, then of course you can even prescribe. Presently, she had a lot of risk factors, so ask her to reduce that, and then you can assess the risk again. And if she is symptomatic, she come and tell you that I have chest pain or whatever it is, then of course you have to investigate.
It's very easy if that is the case, because then you can just follow the guidelines and
Yeah.
yes.
I think that for South Asians, in which of course Sri Lanka and India both are the part of it, We have a very different type of coronary artery disease. We have more aggressive coronary artery disease, and we are associated, our coronary artery disease is associated with higher mortality. So that's very important for it. So coming to the risk calculation in our South Asians, what we have recommended in our algorithm, which we published in 2016 as part 1 and 2020 part 3, we classified patients into 4 groups in 2016, low risk group, moderate risk group, high and very high risk group. And in 2020, we added an extreme risk group, which we further divided into category A and category B. Now we are going to talk that once patient has an ASCVD, there are no further investigation, there is no need for any risk calculation. Go for intensive, aggressive, whatever lifestyle intervention, plus keep LDL cholesterol goal to less than 50 milligram with high intensity statin to be started immediately, number 1. Those patients who are in high risk group, which includes patients of diabetes without target organ damage. As soon as diabetes is diagnosed, you have to start statin in Indian population, because remember that all diabetic patients are pre-diabetic for 5 to 10 years. And all these pre-diabetic patients have insulin resistance. And all these patients of insulin resistance have atherogenic dyslipidemia. So subclinical atherosclerosis is already there when the patient is in a pre-diabetic state, and it's going to increase once patient becomes diabetic. So you have to be, you have to bring down, you have to treat atherogenic dyslipidemia. Now coming to low risk group, which Mr. Fit is there and Mrs. Fit is there. In low risk group, what we have recommended that you go for a lifetime risk assessment. That is extremely important. Lifetime means up to 80 years. If somebody has lifetime risk of more than 30%, then this low risk group becomes moderate risk group and treat accordingly. And along with, low risk group, you always take into lifetime, you always take into account the other moderate non-conventional risk factors like which we are talking of, coronary artery calcium score and all that, that can reclassify these patients. So what we have done for South Asian is a very simple risk algorithm. It's a one table only. If you keep with you, you will be able to treat them.
Do you use the WHO recommended risk score for the Southeast Asia region?
We actually, when we were making this part 1 expert consensus statement, we went into all risk score. And the best risk score was JBS3 by NICE guidelines, because they have included in that South Asian ethnicity.
Living in UK.
In UK. So those who are living in UK, and along with that, they have taken other, inflammatory marker like inflammatory disease. They have taken atrial fibrillation. They have taken CKD. So overall, they have taken a lot of risk markers, which I have discussed right now. And what we have seen that though it is said to be best for South Asian, remember still we are being underestimated by this JBS risk 3 also. We have so much risk. Being a South Asian, remember one thing, we are prone to have heart disease. It's a risk. The question sometimes comes to my mind that all of you should start taking statin after 30 years. That is what comes to my mind. Because if you go into a lifetime risk, I'm just giving you an example because since I'm one of the author of that paper, if 30-year-old male who has LDL cholesterol of 110 with total cholesterol to HDL ratio of 5, no other comorbidity, he is not a hypertensive, systolic blood pressure of 120. If I calculate his lifetime risk, you know how much will be the lifetime risk by JBS3 risk calculator? 37.5%. Means 37 individuals of South Indian or this Indian ethnicity will suffer from MI or stroke by the time he becomes 80-year-old. And if I change this Indian ethnicity into other ethnic group, you know how much risk comes down? To 25. I remember one thing, that it's not nothing what I am saying, it is which I am calculating by JBS risk 3 calculator only. So South Asian being, therefore our statement, our algorithm is basically based upon what exactly our risk is. Therefore, we are different from others.
Can Can I say something, Professor Puri? Completely agree with you, and I think as from an endocrinologist's perspective, the most frustrating thing for us is a cardiologist who is not intensive enough with lipid management. Because if we have a patient who comes to us for diabetes management who's just coming from the cardiologist's appointment and I see the lipid is not at target, I say, okay, you need to start a statin. They say, oh, sir, my cardiologist just saw me, he said everything is fine. So I think that is the biggest challenge that we have. So what I'd encourage most cardiologists to do is, please just make sure that your endocrinologist is not going to ask the question and look into the lipids, because we would love you to be as aggressive as possible.
To just complete, the prevention is not complete without primordial prevention. The primordial prevention is also very important in our type of population. What do you mean by primordial prevention? To prevent the disease while child is inside the womb. That is, make sure the mother gets enough nutrition, the birth weight is ideal. Those are very, very important. Low birth weight people are more prone to get ischemic heart disease in future. So that type of primordial prevention measures also should be taken in the way, especially the problem we have in this country.
Thank you, sir. On behalf of the Sri Lanka College of Cardiology, I'd like to thank very much Dr. Shantaraj, Professor Raman Puri, and Dr. Nivanthi Alvis for that very excellent symposium, and I think we have all benefited greatly from it. Thank you.
Speakers, ladies and gentlemen, now we are going to break for tea. In the interest of time, I would kindly request you all to be seated back by 4:30 p.m. So you can serve yourselves and you may have your tea while listening to the next lecture. Thank you.